Ladies and gentlemen, thank you for standing by and welcome to the Go to the Source Kentucky Medicaid Pharmaceutical Utilization Guide webinar. During the presentation, all participants will be in a listen-only mode. If you'd like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If at any time during the conference you need to reach the operator, please press *0. As a reminder, this conference is being recorded on Tuesday, May 14, 2013. I would now like to turn the conference over to Sarah Walsh, Knowledge Officer. Please go ahead.
Thanks, Sarah. As she said, my name is Sarah Walsh, and I'm with the Foundation for a Healthy Kentucky. Thank you all for joining our call today. Before I hand things over to Mike Childress, who's going to lead this discussion, I wanted to take a moment to tell you a little bit about what this webinar series is. If you've participated in one of our earlier calls, just bear with me. I promise to be brief. But if this is your first Go to the Source webinar, you may still be familiar with the Foundation's Health for a Change training series. Health for a Change is a series of webinars and in-person workshops that the Foundation for a Healthy Kentucky has offered for the past few years. Our goal is to help build capacity at small nonprofits and emerging health coalitions, really to help the folks who are doing the important work of fostering change in Kentucky do their jobs better. This year we wanted to expand that effort to specifically address the needs of more serious data users, researchers, epidemiologists, grant writers, map coordinators, community benefit planners, data wonks really, and that's why we started Go to the Source. If you've ever talked to me for more than a couple of minutes at a time, you've probably heard me name check KentuckyHealthFacts.org. And really what's a little shameless plug among friends. Kentucky Health Facts is designed, this is a website that the Foundation sponsors, and it's designed to provide anybody, data wonks and novice users alike, with an overview of the health needs and resources in their community. If you've not been, I strongly encourage you to check it out. We hope it's user-friendly and very accessible. But we also recognize that sometimes you need to dig a little bit deeper than the data on Kentucky Health Facts allows. Sometimes you have to, quote unquote, go to the source. You've got to go back to the original sources of information to learn more. And that's what we're hoping to do with this series, to introduce you to some of the key health data tools and resources that we have available in Kentucky, and let you get to know the people behind those sources so you can know where to turn with questions. Before we begin today's discussion, we're going to talk about the Kentucky Medicaid Pharmaceutical Utilization Guide, but I also wanted to remind each of you of the other events in the series. If you've not signed up yet, you can register for all the webinars at through a link on our website, www.healthy-ky.org. Last month in April, we heard from Janae Grandmont about Health Landscape, which is a free web-based mapping tool where you can analyze existing data and upload new data sets that you may have at your organization. It really is a powerful tool, and it was cool to learn a little bit more about that. Dr. Sarah Jeannie Knotra also told us about the Kentucky BRFSS, or Behavioral Risk Factor Surveillance System, which is a really powerful resource for health status and behavior data in the state. If you missed it, recordings for both of those webinars are available on our website. And next Tuesday, Jennifer Chabinsky and Mark Carosa are going to tell us a little bit more about the Kentucky Health Issues Poll and OASIS. The Kentucky Health Issues Poll is a large-scale annual public opinion poll that our foundation sponsors in partnership with the Health Foundation of Greater Cincinnati. And it's just one of several free data sets that are publicly available on the OASIS data site. OASIS is an acronym standing for Online Analysis and Statistical Software. So if you aren't affiliated with an organization that has access to SAS or SPSS, or you don't remember how to use those tools, because I certainly have forgotten from time to time, it's a much more user-friendly and easy way to analyze the data online for free. You can also download those data sets if you do know how SAS works, unlike myself, and do your own custom and secondary analysis of the data sets that are available there. Next month, we're going to start in with a webinar from Michael Price at the Kentucky State Data Center. If you're not familiar with the Data Center, they are a key source for population estimates, and census and demographic data for the state. I always say it's really the denominator for almost every health statistic we ever report. So that should be an exciting call. In July, I'm going to talk a little bit about the Kentucky Parent Survey, which is a new data source here in Kentucky. And Amy Swan is going to tell us about the Kids Count Data Center 2.0, which is an update to an existing resource that the Annie E. Casey Foundation sponsors. And it's going to launch, and she's going to show us how all the new features work, and I think that will be fun as well. Because this is our first time offering Go to the Source, we are a little bit making this up as we go along. And I hope that all of you will let us know what you think. If this was a helpful call, we're going to look at repeating this series next year and expanding it possibly to cover different data sources. If there's something we can do better or do differently, we really hope to hear that back from you. So shameless plug, please check your email tomorrow. You're going to get a link to a short evaluation. It should just take 2 or 3 minutes, but you are data people, so hopefully you understand the importance of answering that and providing us some evaluation information. Okay, that was my shameless stealing of time. With all of that done, I want to dive into today's webinar and what we're actually here to talk about today. Our speaker is Michael Childress, who is a research associate at the Center for Business and Economic Research, or CBER, in the Gatton College of Business and Economics and the College of Communications and Information, both at UK. He previously served as the Executive Director of the Kentucky Long-Term Policy Research Center. Mike and his team at the Long-Term Policy Research Center conducted research and policy analysis related to kind of all branches of government, and they looked at all kinds of policies and what's going to work and what wasn't going to work for Kentucky. And they shared that information both with policymakers and the general public. More recently, Mike has used Medicaid records to give us a better understanding of how healthcare is delivered across the state, and he's going to tell us a little bit about the patterns that emerge when we ask what medications are being prescribed where and to whom. So without further ado, I will hand the controls over to Mike.
Okay, thank you, Sarah. Good afternoon, everyone. My name is Mike Childress, and I think that technology is wonderful. I can't believe that Sarah is sitting 90 miles from me as I sit here in my office at the University of Kentucky, and we're coordinating on this, and who knows where each of you are sitting right now. This is an important topic, clearly. It's an important topic for a number of reasons. One reason is we're talking about a lot of money. Over $6.6 billion, that's with a B, was expended in outpatient medication in Kentucky for Medicaid Pharmaceuticals from 2000 to 2010. $6.6 billion. Now that's a small fraction of the total Medicaid budget, but it's still a lot of money. It's also important because these drugs, these pharmaceuticals, can transform someone's life. They can, by extension, transform a community if there is widespread chronic disease. And then also we have a part of this presentation I'm going to talk about analgesic narcotics, which is probably the most egregious example of this trend of the non-medical use of prescription drugs, which has, of course, exacted a truly heavy toll on individuals, families, and communities across the state. Now this is what the cover of the report looks like. It's a nearly 400-page source book on drug usage in Kentucky that has been paid for by Medicaid. Now there are a couple of qualifying statements in there. There have been a lot of, there's a lot of pharmaceutical utilization that takes place in Kentucky. That's not included in this report. This only looks at Medicaid. Doesn't look at private insurance, doesn't look at Medicare. Doesn't look at what somebody might pay out of pocket. It focuses on the years from 2000 to 2010, so that's 11 years inclusive. And it's really table after table after table. Of the 388 pages, probably 360 pages are just tables. that are organized by geographic areas, counties, and so forth. And so each of these tables has data on the number of prescriptions that were written, the cost, and the grams dispensed. And it's organized by therapeutic class. And I'm going to talk a little bit more about that in a minute. As I indicated earlier, it's organized by various geographic regions. And there are results shown separately for children and adults. And then within those two categories, we look at male, female, and then white and minority. And this report can really be used to provide important information about the health profile of an area. It could be used to strategically allocate resources within a region, within the state. And it can also be used to improve health literacy, not only among the population, but also for providers. Unlike most reports, this one, I think, produces more questions than answers. And here's a sort of an example. The next 2 or 3 slides here, I want to give you kind of a quick overview of what this thing's about, sort of a 30,000-foot look, and then we're going to dip down a little bit deeper into some of this information. This is Table 6, early in the report. The top 50 therapeutic classes by cost for adults on Medicaid, aggregated from 2000 to 2010. And so let me bring my markup tool here. So you see the number 1 therapeutic class, and these therapeutic classes are signified or indicated by a 3-character alphanumeric designation, except for in the case of unclassified or OTC, over-the-counter, which is hashtag, 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 but otherwise indicated by these 3 alphanumeric characters. And so H7T is an antipsychotic atypical medication, and it is the most costly therapeutic class over this time period for adults. And you can see that Medicaid expended $486 million during this time period for that therapeutic class. Now I should point out that there are typically numerous specific drugs within each therapeutic class. I've seen some that have had as few as 2 or 3 drugs, and I've seen some that, there might be 40 drugs. So this is the most costly, almost $500 million just on antipsychotics, the number 1 drug. Number 4 on the list is D4J, proton pump inhibitors. Okay, and this is something that most of us maybe have taken. For an example condition would be acid reflux or ulcers, and an example drug is Prilosec. Others are Nexium, Prevacid, and it's number 4 on the list. Now, go to the next slide here. There's an interesting kind of story, I think, to tell about this. So this is just focusing on the proton pump inhibitors. So these 2 counties, Clinton County and Simpson County, both located along Kentucky's southern border, along the Tennessee border, are separated by just 65 miles. Yet the adults in Clinton County have the highest utilization of that particular therapeutic class in the state, and Simpson County has the 2nd lowest. So automatically, that raises some questions. The relative difference is about 4 4 times greater in Clinton County on a per person basis, on a per eligible, Medicaid eligible person basis, 4 times greater in Clinton County compared to Simpson County. And I'm just talking about the adults here. So, and we know it's the 4th largest in terms of cost. So some important questions kind of naturally arise from this, which is, what's going on? Why? There could be a lot of reasons. Is there, I mean, you know, are the adults in Clinton County getting too much? Or the adults in Simpson County getting too little? Or are they both getting about the right amount that they should be getting? And there's some environmental factor causing 4 times as much gastric distress in Clinton County compared to Simpson County. Here is an illustrative table. This, I'm not sure what, yeah, here it is. This is page 362 of the report. And you can't really see it too well, but this is Simpson County, okay? And I wanted to show this to illustrate what a table looks like, okay? And so we've been talking about proton pump inhibitors, and you can't probably, it's probably hard for you to see it, but that says D4J. That's what we've been talking about. And there is 262.5 grams per 1,000 member years, which is, I'll explain a little bit more in a second how that's calculated. It's analogous to on a per capita basis. And you can see that it's for all adults. Now, if you want to look at just female adults or male adults or just white adults or just minority adults, here are the grams per 1,000 for the top 50 therapeutic classes in terms of the largest amount of grams dispensed for adults in Kentucky. So what we did was we looked at the top 50 for Kentucky and then made tables for each of the geographic units that would reflect those same therapeutic classes. So these may not be the same top 50 for Simpson County, but we wanted to be able to compare from county to county to county. So we used the state top 50 as the benchmark. Now you'll see that there are some missing cells, some blank cells in this table. And those are suppressed values. Anytime that there was 30 or fewer cases in a cell, we suppressed it for privacy reasons. Now over here in this set of columns we have the dollars that were spent for all adults and then by gender, female and male. And then in this column we have the numbers of prescriptions. And it's just the total. We kind of ran out of space. We wanted to keep each geographic unit on one page, and so we weren't able to put the detailed information about gender and minority or not in this group, and we had to focus, we decided just to focus on the gender here, but here we talked about all the breakouts. So this is what an illustrative table looks like. So how to use this report? You know, why and just how can you use something besides helping you fall asleep at night that has nearly 400 pages of tables? Well, I think that there are really kind of 2 things that I see, and there may be more that you see. First, to generate discussion at the community level about the relative differences. So if you're in Clinton County, you might be curious, right, at the community level, if you're a public health official, if you're a provider, if you're a health advocate, if you're just an interested citizen. Why is it that we take so many more proton pump inhibitors on a per person basis here compared to just 4 counties over? Another way in which this can be used, this report, is as a pool of data, I think, for researchers who might have an interest in exploring relationships between other variables in some of the outcomes and some of the data, some of the pharmaceutical data. And I have an illustrative example later in this presentation on how you might do that. So I think Sarah gave you some background. Here's some additional background. This work was funded by the Foundation for a Healthy Kentucky. They put out an RFP 3 years ago, actually, for a health market analysis. And so part of that health market analysis work was pharmaceuticals. We had a contract in place by March. It took some time to get the Institutional Review Board approval in place by fall of 2011. And then the final reports came out in August and September of 2012. Now the first thing listed here is the Kentucky Medicaid Pharmaceutical Utilization Guide, which is obviously what I'm talking about here today. But there are three other related pieces that are available on the CBER website, in which I'll provide that URL to you at the end of this presentation, which focus on three kind of interesting therapeutic groups: analgesic narcotics, antipsychotics, and ADHD medication. The first two of these, analgesic narcotics and antipsychotics, have been in the news a lot here in Kentucky over the last couple of years. ADHD medication nationally has been in the news, not as much, but there was a New York Times piece within the last year on the front page about its usage, or or perhaps overusage. And then another piece of this that I'm not going to talk about today is an analogous piece that looks at the mental health diagnoses in Kentucky, and that's a similar kind of report. It's a series of tables organized at a geographic level: county, Berphus region, area development district, region of the state, west, south, central, east, west, or state level, just like this report. These are, again, to emphasize, Medicaid pharmaceutical claims data. There are millions and millions and millions of claims records that I analyzed to produce the report. And as I indicated earlier, the report is organized by therapeutic class, not by individual drugs. As you saw by the illustrative table, I think I was showing you the adults, but there would have been another table for Simpson County just for children. And in this case, we're defining children as 18 years and younger, adults 19 and older. We look at prescriptions, that is to say the numbers of prescriptions, the cost, and the grams. And when you look at these, there's a important but subtle distinction to keep in mind. And so I'm sitting in Fayette County, and let's pretend I'm looking at the table for Fayette County, and I'm looking at the column that shows the numbers of prescriptions. Those would be the numbers of prescriptions written by providers in Fayette County. Now the thing about Fayette County is that it's a big medical center of gravity for Kentucky. So we have a lot of people on Medicaid or not on Medicaid who come to Fayette County for the medical treatment, and they might get a prescription written while here. If they were on Medicaid, and let's say that they lived in Pike County and they drove to Fayette County to see their provider, that would show up in my records as a prescription that was written in Fayette County to someone in Pike County. The cost would be reflected in Pike County, and the grams would also be reflected in Pike County. Now there are hundreds and hundreds of therapeutic classes, and so we had to get it down to a manageable level, and a 8.5 by 11 size page can accommodate about 50 lines. So there was somewhat of an arbitrary, but not entirely arbitrary reason why we decided to cut it off at 50. It turns out that 50 is a pretty good number. Whether you're looking at the 50 top number of prescriptions written by therapeutic class or the total number of grams or the cost, if you look at the top 50 for either children or adults, you're getting the lion's share of each of the records in each of those categories. I have some numbers later in the presentation, but it's generally over 80%, and in terms of the numbers of prescriptions for both children and adults, it's 96, 97%. So with the top 50, we're getting most of the action. Now, again, just to reiterate, the data are presented for various geographic regions. The county level, Kentucky has 15 area development districts, so they're also organized at the ad level. There are 39 behavioral risk factor surveillance system regions that have been identified in Kentucky, and so they're also presented at that level. I also, while respecting the 15 area development districts, the integrity of the 15 area development districts, organized them so that we had a Eastern Kentucky, a Western Kentucky, an urban triangle, and a South Central Kentucky. So there are 4 regions, and then at the state level. And then finally, all of this is normalized to the size of the Medicaid eligible population so that we can compare, apples to apples. You can look at Jefferson County and you can look at Robertson County, even though the sizes of the relative size of the population of each county is probably the widest in the state. Since we're normalizing it to the size of the Medicaid eligible population, you can compare those numbers. Now, I use a clumsy title per Medicaid 1,000-year person years. Just think of it in terms of a per capita distinction. Medicaid is in the news a lot, right? Particularly with the Affordable Care Act in the news a lot, but even before then in Kentucky. It's been something that has been increasing in size, both in terms of the number of beneficiaries. Here you see in the chart the number of beneficiaries in Kentucky from 1999 to 2012, how it's increased, but also in terms of the size of the budget. It's a $6 billion program in Kentucky. And the most recent data that I have from the National Association of State Budget Directors, it's the second largest expenditure category for Kentucky, second only to higher education. So nearly 23% of the money spent by Kentucky state government is spent on Medicaid. Some of that's state money, some of it's federal money. But that's second only to higher education at almost 24%. So it's a lot of money. We have a lot of people. In Kentucky, it was 18.2% of the population compared to 16.2% among our competitor states, which are mainly the bordering states and some states in the southeastern Kentucky that are viewed as our economic competitors, and almost 16% nationally. Okay, what about antipsychotics? So this is a really interesting bit of data. And as I said before, I picked 3 things that I want to kind of dig into here. And there is an issue brief associated with this topic, as well as ADHD and analgesic narcotics. And there are 2-page issue briefs with a map, so it's 3 pages. If I have both children and adults, then I'd have a second map, so 4 pages. So it's just these issue briefs just kind of give you a broad overview of what's going on with respect to this topic. Of the hundreds of pharmaceuticals available through Medicaid, antipsychotics are number one, or there's more than one therapeutic class for antipsychotics, but the number one therapeutic class is H7T in terms of cost for both adults and children, and it is an antipsychotic. So it's important for many reasons, but it's important for cost reasons. It's the most expensive therapeutic class over this time period. So what does this report tell us, and what does this issue brief indicate? This particular therapeutic class, the state average for children on a per eligible basis is 280 grams. And so what about the race differences? Now, if you recall, we looked at the table for, I think it was Simpson County, and we see there was a column for whites and there was a column for minorities. Well, if we looked at that for the statewide numbers, there is a table in there that is just Kentucky statewide. We would see that there is a rather large difference for children between whites and minorities. And that's reflected right here, that the per eligible gram consumption, if you will, for whites is 226 grams. And remember, the state average is 280. But for minorities, and this, when I say minorities, this is principally African Americans, it is nearly 500. So it's over twice the amount compared to whites. That in and of itself, at the state level, should raise some important questions. And indeed it has. I actually briefed this to the leadership of the Cabinet for Health and Family Services back in September or October, and at that time the Secretary indicated she was going to form a task force or a working group to dig into this, because this is a really interesting example here. Bath and Christian counties. So Bath County is in the eastern part of the state, and Christian County is in the western part of the state. And if you know your demographics across Kentucky, you know that Christian County has a large African American population. Now let's look at the differences here. Between white children, between Bath and Christian County, it's 240 and 247 grams respectively. Okay? And essentially no difference between Bath and Christian County for white kids. What about minority children? Well, in Bath County, they got almost 3,000 grams per eligible, and in Christian County, they got about 113 grams. Obviously, that's a very large difference. Now, what's going on here? Well, that's why the Secretary decided to form this working group. Now, we know there have been a lot of studies that have come out nationally that have looked at this, and people have concluded that the majority of children receiving antipsychotics have not been diagnosed with a condition for which the FDA has approved their use. There's a lot of stuff going on here, and you really have to kind of dig into the data and examine what's going on at the community level, I think, to fully appreciate and understand what can explain these differences. It could be, and it is the case, that you have a lot fewer minorities in Bath County, and so you have a small sample size here. And so maybe you just have a handful of kids who are consuming the bulk of these meds, and that's what's driving the average up. Maybe. Also, it could be that providers prescribing different medications. There are different medications within this therapeutic class of antipsychotics that can be used. There's older medications which require a lot more grams, and there are newer medications that are much more powerful and can achieve the same effect, which require a lot fewer grams. So it's possible that the kids in Christian County are getting the newer medications or being prescribed the newer medications, and the kids in Bath County are being prescribed the older medications. And it's also possible that there's something much worse going on here. And that's why I said earlier that this report raises more questions than it answers. And that's what it's designed to do. I don't have the answers. This report doesn't have the answers. It's really an antiseptic look at the data that is provided back to the people in these communities so that they can have a conversation. You know, there may be a good reason for these differences. And if you get the healthcare advocates and the providers, interested citizens and others around a table and look at what's going on in their county, for example, and compare it to surrounding counties or compare it to the state overall, I would think that they could have an educated and informed conversation about some of these outcomes and maybe come up with some answers as to what explains these differences. Now, in terms of some general trends here, and again, this is a chart that is in the issue brief, not in the report. It shows that the rising use of antipsychotics for both adults and children, and I think you'll note that this steep decline here for adults from 2005 to 2006, and then leveling off. Before you get too excited here, this is when Medicare Part D came into effect, and so a lot of adults whose medication was being paid for by Medicaid, their medication switched over and was beginning to be paid for at that time in 2006 by the newly created Medicare Part D. So it is the grams per thousand per eligible over this time period, but it's an artifact of a different funding stream coming into effect, paying for the other grams. For the children, you see this rising use, and it doesn't look like much of an increase, but in reality, that's about 81 grams, and that's a little bit over 300 grams. So this is a 270% increase in the number of grams per eligible during this time period for children, which is a significant increase. Now, if we focus just on the children, here in this chart we see, again, from 2000 to 2010, it broken out by minority, male, white, and female. And you can see where the minorities, again, this is grams, this is the amount received on a per eligible basis. You can see where it's going up for all groups, but for the minorities, and this is minority boys and girls, it's going up more and higher than every other group here. Males are second. White males and females are here, and the females at the bottom. There's also a table in this issue brief that shows the data for each of the counties. And so here, Leslie County for kids is the lowest amount. And this is not just the one therapeutic class of H7T that I was talking about earlier. Here it is about 8 or 9 different therapeutic classes that are all antipsychotics. Leslie County was the lowest, and Marion County was a factor of, I don't know, about 12 times greater, again, for kids. And so if I'm looking at that, and I'm in Marion County, I'm asking myself, wow, why why are the kids in my county receiving so much more antipsychotics on a per eligible basis than compared to the lowest, which is Leslie County? And if I'm in Leslie County, I'm wondering, wow, what's going on here? Why are our kids being appropriately diagnosed and treated? Now I have a map that shows the dispensed antipsychotics, and again, this is children. And what I've done here is the green counties are from 0 to 250 grams per 1,000 eligible. Okay, why 250? Well, that was the median, right? That was sort of the midpoint. So I just said the midpoint below, we'll call that a green county, right? They're below average. They're below typical. And then, somewhat arbitrarily, created the next category, 250 to 500, and then the next category, 500 to 630. And so you can see here's Leslie County in eastern Kentucky, and then Marion County right here in the central part of the state. And you can see that, that eastern Kentucky is basically green, but the red counties are more or less sprinkled throughout the state. Now, again, this is grams, so this reflects the resident, the county of residence for the individual receiving the medication. This isn't driven by, okay, well, there's a mental health center in such and such county, and all the kids from everywhere are going there. And so, no, that would be reflected in the number of prescriptions, but not in the grams. I have the same kind of chart for adults. You can see where the gram totals are a lot higher. Again, we have this red over here in the western part of the state. What about ADHD medication? Some of the example medication in this group is Adderall and Ritalin. We're very, we've heard a lot about these drugs. It's one of the most costly therapeutic classes at $280 million. It's a great thing for kids who need it, right? It helps them focus and to concentrate. But again, there's been a lot of studies and a lot of literature that have suggested that, when they look at the rising use over time nationally, it's not just a Kentucky phenomenon. They wonder whether kids are being diagnosed properly. Is it the fact? Is it the case that that the percentage of the population of children in this country who are truly ADHD is increasing, or is it perhaps the case that it's being overprescribed? When you look at, here's an important difference. One of the therapeutic classes for ADHD, the largest one, the state average is 244 grams per 1,000 eligible children. Leslie County again, okay, had the smallest, 58 grams. Henderson County had the largest, nearly 10 times greater. And here over time, again, we can see the increasing consumption, if you will. This is children, grams per 1,000. The western part of the state has increased tremendously. All have increased, but you can see the western part of the state, it's really high. The eastern part of the state is much lower. And then here we look at the minorities again. This is like what we saw with antipsychotics, much higher, then followed by male. The females down here. And then if we look at a table, you can see Henderson County is, to a certain extent, really driving what's going on out west. And then Leslie County, again, when you look at 3 therapeutic classes, not just the one, but the 3, well, that says analgesic narcotics, but that's a misprint. That's really ADHD meds. Sorry about that. You can see that it's up to 112 grams, and then if we look at the state map, again, these are the kids. You see Pulaski County, they're getting in the context of eastern Kentucky, they're kind of high, so is Rowan County. But otherwise, eastern Kentucky is pretty green. Again, this is either at the median or below, where the hot spot in Henderson County is right here, is out west. Again, why? Now, there was funny, I came across a study that was published in 2004. This is different data. This is using DEA data, and they got it at the zip code level. And this is sort of wholesale medication that gets shipped to various zip codes. And you can see right here in Kentucky out west, that big bright red spot, that's what we were looking at in the previous slide. And so, so this is from 2000, but it was published in 2004. So this has been going on for a long time. The final group that I'll talk about here is analgesic narcotics. And this is one that has obviously received a lot of attention in Kentucky. For adults, it's the most of any, more prescriptions are written for analgesic narcotics than any other. When you look at the amount of grams, you see again these huge differences from county to county. The largest is Martin County. The smallest, and these are for adults, is in Shelby County. Now this is eastern Kentucky. Shelby County is close to Louisville. And again, this is 12 times higher. It's an important issue, right? Because we have a lot of diversion for non-medical use. And it's not just Medicaid, right? I'm focusing on Medicaid here, but this is an important issue outside of Medicaid as well. And you also have a situation where even if people are receiving it appropriately, so there was a study that came out within the last year that found that injured workers receiving high doses of, say, OxyContin, for example, because of a workplace injury, stay out of work 3 times longer than workers with similar injuries getting lower doses. And they tend to end up costing us more. It's kind of interesting how that happens. Again, we see the change over time. The eastern part of the state is the highest, and again, these are adults, and we see that dip from 2005 to 2006. As we went over to Part D, we see the urban triangle down at the bottom. The counties, as I talked about, Martin County and Shelby County, but here are all the counties, and then here's a map, and we can see the hot spots, Clay County, Martin County, and I think that's Johnson County. It's kind of blurry on mine. I know it's blurry on yours, and I don't have a hand free to look at it. I broke it up into 4 categories. You can see where most of the state is below the median, but the hot spots are here in the eastern part of the state. Now, using the BRFIS data, the Behavioral Risk Factor Surveillance System data, to dig deeper. If you're a sophisticated user of SPSS or Stata or SAS or Excel, you could use the data in this report to test some interesting hypotheses and maybe explore some questions about what accounts for the differences in these geographic units. Well, I wanted to use the BRFIS regions, and so a while ago, some folks here at UK at the Markey Cancer Center and in the College of Public Health, and worked with some folks in the Kentucky Department of Health, Public Health, to come up with 39 BRFIS county groups. Now, there are a handful of counties where the sample sizes are large enough where you can get a single county estimate, and they're listed here, beginning with Boyd and ending with Warren. So big counties like Jefferson and Fayette and Davis County, rather, and Owensboro. But the rest have to be clustered. And so because the sample sizes are too small. So I took these data and I pulled one question from the BRFIS, from the annual surveys. The question is, would you say that in general your health is one of these 5 things, excellent on down to poor? And you know, when you see this kind of thing, typically people take the bottom 2 categories, fair or poor. So let me go back, and they'll lump those together. And so you would expect, I would expect a priori, my hypothesis is that the higher the percentage of people in a geographic region who have either fair or poor health, the higher the amount of analgesic narcotics I would expect to see used in those counties. And here the scatter plot, you can see that there's a nice little trend line here. Okay, as the percent of adults goes up, right, on the x-axis, who indicate that they're in fair poor health, we see the amount of grams being used also goes up. So you can take the residuals. So what I'm really kind of interested in are the residuals, right? So why is this county, and I'm sorry I can't remember what BRFIS region that is, but I'm guessing it's obviously it's on the high end. It's the one, the Eastern Kentucky ones. Why is it so much higher? This line would indicate my predicted point, and this is significantly higher. Well, this group is below the line, right? So they have much lower usage than expected given the amount of fair or poor health in that community. So I produced a little map illustrating those residuals, and here you can see the size of the residuals with a green being below, that you're below the line, that you have less analgesic narcotic usage than expected, with red being the highest amount, more than expected. And so this is just a simple kind of bivariate regression thing. I'm actually trying to get some data from the cabinet to explore some other hypotheses, because you know, when you look at this, this is like I-75 and Mountain Parkway, and you've got Kentucky State Highway going up through here. So I have some ideas about what might help explain some of this. So as we get on the home stretch here to finish off this thing, navigating through the report, some important tables. So table 1, this is the most important table. As I told you, there are hundreds and hundreds of therapeutic classes. There are 119 in this table, and these 119 are the ones that are the top 50 for either the number of prescriptions or the cost or the grams for children and adults. And so in each case, it's the therapeutic class, a little description, an example condition, an example drug, and then where that therapeutic class shows up. So you would refer back to this table 1 as you were looking at your particular county, for example. Other important tables, 2 through 7, are the top 50 for children, and by the number, by the cost, by the grams, and likewise for the adults. And so here's table 4, which is the top one for kids, for children, and you can see at the very top of the list, these are the grams. Therapeutic class W1A, which is antibiotic. It's a penicillin, and you can see that by far the highest amount of grams went for that. Hopkins County had the smallest, about 5,000, and Wayne County had about 18, almost 19. So again, you ask yourself the question, why am I so much higher in Wayne County? Well, it could be, okay, as I look at the next slide here, there's more than one therapeutic class that's an antibiotic. So maybe part of that difference is a prescribing difference, that the providers in one county prefer to use the antibiotics in this class compared to these other ones. These are all antibiotics. See, this is a table for Hopkins County, and these are the grams. These are for kids. And if I add these up, I think this is just under 10,000 grams. Let me page to that page. Sorry, folks. Yes, it is about 9,300 grams. But if I look at, here's Wayne County, the highest. This is almost 25,000 grams. So it's higher across the board. So again, if I'm in these counties, I'm wondering, why are we getting so many more antibiotics, our kids, for that 11-year period in our county compared to Hopkins or any other county? I want to get the people who care about this together in my community, to take a stronger look at this. Okay, so in conclusion, why the differences in pharmaceutical utilization? Is it because of prescribing practices? It's just you got a provider in one county prefers one kind of drug that's in a therapeutic class, and then a provider in another county that prefers another? Or are there some environmental factors causing more sickness or disease in some of these counties, or is there something else going on? I don't have the answers to this. It's my hope that the people in the communities will use this information to ask these kinds of questions. And again, like most reports, unlike most reports, this one is designed to elicit questions rather than provide answers. Communities should really compare themselves to other counties, regions, or the state average. Researchers should combine these data with other indicators, like I did with the BRFIS, to try to help explain the differences. And ultimately, the goal is to shed light on the health of Kentucky's communities. So here's my contact information, my phone number, and my email here at UK, and that concludes my part of the presentation. Thank you.
Thanks, Mike. This is I can't speak for everyone else, but I am completely blown away by the volume of the information that's available in this guide and the magnitude of some of the differences that you've shown us, that it's not just a little bit different in certain communities. These are major differences that really do warrant further investigation. We only have a couple of minutes, but if folks want to chat in their questions, we'll try and address those as they come. We did have one question for you, Mike, about further granular detail. Is it possible to get this information at the zip code level or anything kind of drilled down further, or how would that go? How would someone go about finding this out?
Yeah. I got the data. Some of my partners, and I failed to mention this earlier, partners in this effort also include colleagues at the College of Pharmacy in the Institute for Pharmaceutical, let me see, it's IPOP, and they're the ones who have the relationship with the cabinet and got the data. So it's the Institute for Pharmaceutical Outcomes and Policy. No, unfortunately, I don't have the data at the zip code level. I have the data at the county level. Now, having said that, the data do exist at the zip code level. And the folks at IPOP have that. Now, does that mean that you can just call them up and say, hey, send those to me? No. Unfortunately, it's not that easy. So I guess the short answer is no. It is my hope, and I really don't know what the status of the Cabinet's inquiry into some of this. As I said earlier, I gave essentially the same presentation to the upper echelon of the Cabinet, the Secretary, Deputy Secretary, all the commissioners. And they were very concerned with it, particularly some of the antipsychotic and ADHD information. and really the antipsychotic information on kids. And so the Secretary indicated that because they have access to this stuff, right? I mean, at the really granular level. And they don't have to go through an IRB process to get into it. And so they were going to really look into this and try to find out what was going on. So you may not be able to get at the zip code level, but it's my hope that the people who have the data are doing that.
Great. We also had a question about your issue briefs. You mentioned that the full guide is available on the CBER website. Is that also where we go for the issue brief?
Yes, it is. And so on this last slide where it indicates the guide is available at cber.uky.edu, the issue briefs are at that same website. You got to click around a couple, publications and then issue briefs, and then you'll see them listed there. If you have a hard time, I think you can find it. But if you can't, just send me an email and I'll send you the URLs.
Great. Well, I think we're about out of time, and I'm not seeing more questions come in over chat unless somebody's furiously typing. I'll ramble a minute to buy them some time. I do have this general concern about what all the acid reflux in Clinton County is about, if there's just some fantastic barbecue that all of us need to get in on down there or something else going down. But this has been really helpful for me, Mike, and I just, on behalf of everyone whose phones are muted, thank you so much.
Well, thank you. It's been my pleasure.
And I think with that, we're going to let everybody get back to their afternoon, and thank you all for joining us. Feel free to email Mike or contact us at the Foundation if you have questions. We hope to see you back next Tuesday. Thanks, everyone.
Thank you. Ladies and gentlemen, that does conclude the conference call for today. We thank you for your participation and ask that you please disconnect your lines.